Good afternoon. I am lucky this afternoon. I have with me Kokate from Minneapolis, Thomas Zeller from Bad Krozingen, and my friend Koen Deloose from Dendermonde in Belgium. We had a full day of work. We started this morning with difficult cases, and we just finished a few minutes ago with another cases. It was all around SFA and popliteal lesions, talking together, vascular surgeon, cardiologist, and researcher about how to manage and how to treat today chronic lesions of the SFA. Could we summarize what was the substance of our discussion? Koen, what could you say?
Well, the nice thing that we probably, Max, we expected some firework and hard debates between cardiologists and vascular surgeons and whatever. But we were all surprised that actually there was no debate. There was firework, but not a competitive firework. So we had more or less, as during the talks, as during the cases, the same treatment algorithm and treatment strategy that we can point out here. I was surprised on this. And I notified that this algorithm was based on hard scientific data, and not really on reimbursement issues. Of course, when we are going back to our different countries, we are faced with these reimbursement issues, and that can influence our scientifically based treatment algorithm.
Thank you. Thomas, it was really a pleasure seeing you working today with precision, accuracy, with your scientific background. Really, it was something I learned a lot. What is today your vision of drug-eluting balloon and stenting in the SFA?
Well, I would say the choice between the use of drug-eluting balloons and drug-eluting stents is mainly driven by reimbursement issues, and this is differing from country to country in Europe. In Germany, for example, we have the situation that we have an adequate reimbursement for drug-coated balloons, but we have no dedicated reimbursement for drug-eluting stents, neither in the SFA nor below the knee. So we get the same reimbursement as for a bare metal stent. So besides potential dedicated indication for drug-eluting stents, the use of drug-eluting stents is somehow limited by the missing reimbursement. And for me, I'm following more or less the rule of leaving as less metal behind as possible. So vessel preparation is a big issue in my cath lab. That means vessel preparation before using a drug-eluting balloon, and drug-eluting stents are reserved to potential dedicated indications where a balloon-based approach alone is not sufficient.
Mm-hmm. Jay, you worked on having the transferring, technology of coronary drug-eluting stent to peripheral, and you saw the differences between restenosis in coronary and peripheral. Could you tell us more about what are the differences that you saw?
Yeah, so from our perspective, there are two large buckets. There's differences in the environment between the coronaries and the SFA, mechanical environment, the pathophysiological environment. But there are also differences in terms of the technology that has been applied in the coronaries versus that has been applied historically with Strides and Sirocco, as well as Silver in the SFA. So what we're trying to do is take some of the technology that we used in the coronaries and apply that now to the SFA. I would say the early clinical results are very promising. Again, the world of drug elution that happened in the coronaries, I think we could all agree is happening in the SFA today.
Excluding the problem of cost problem expenses, we all agree today that when it is necessary to debulk, it is preferable to debulk. When it is necessary to be satisfied with drug-eluting balloon alone, that's the way to stop. And if necessary, the way to go is probably drug-eluting stent in the future in SFA. Is it a paradigm or an algorithm that you consider acceptable, or you think it should be altered?
No, definitely, and definitely we have two constants in this. It's vessel prep, and vessel prep. Depending on the lesions you have to tackle, or when these lesions are thrombus containing, soft, heterogeneous, we go for some thrombectomy devices or thromboaspirational devices. When it's tight lesion, we go for debulking devices. We can only do POBA as vessel prep, but it is important. And then on the second hand, it's drug-eluting technology. If you need scaffolds in the format of a drug-eluting stent, if you don't need scaffold in the format of a drug-coated balloon. I think these are two constants in all our SFA popliteal work right up to date.
So what is going to last for bare metal stent, Thomas?
Bare metal stent will survive because they are the bailout devices after insufficient vessel response to drug-coated balloon. So we will probably never combine a drug-eluting balloon with a drug-eluting stent. So that means that that the bare metal stents will definitely survive. What they need to become is more durable with regard to fracture resistance. And probably we need to follow also in the periphery the same strategies as in the coronaries to reduce the amount of metal as much as possible in order to reduce the vessel wall response. Then what we did not yet discuss is that we probably can apply a change in conformation of the stent into a helical design to change flow patterns in order to reduce to improve long-term patency and performance of stents, which might be used in addition to drug-eluting balloons. This is still work in progress.
Mm-hmm.
But we will never end up without bare metal stents, even in the future, even in the bright future of drug-eluting balloons.
How do you see the drug applied to drug-eluting stent? Appearance of sirolimus or other limus instead of paclitaxel?
It's certainly under investigation, both for drug-coated balloons and drug-eluting stents, and there is nothing in terms of the drug that is not applicable in the case of both drug-eluting stents and drug-coated balloons. In the SFA, we believe that it is just a matter of finding the right polymer or the right excipient to deliver these drugs, whether it's sirolimus or in the case of paclitaxel, we may have already figured those things out.
Maybe we could discuss one point that is important for the people, which is the dual antiplatelet therapy of this patient. What is today recommended in terms of dual antiplatelet therapy? 1 month, 2 months, 3 months, 6 months for the drug-eluting stent, particularly in your product, in your opinion?
So what we have studied in Majestic and Illuvia is similar to what has been used in Silver PTX clinical trial at 60 days. However, it's also important to note that almost 80% of the patients in Majestic were already on DAPT at 1 year. I think we still will need to inform ourselves based on Imperial, but it is likely, again, I will leave it to the opinion of the physicians. There is a drug present for approximately 12 to 15 months, and there's a polymer present for life. So that those have to be taken into consideration.
Basically, we don't have robust data which give us the information about the really necessary duration of dual antiplatelet therapy. We even do not know whether we need dual antiplatelet therapy in the periphery. There's no study available comparing monotherapy with dual antiplatelet therapy. But what I can tell you, what we learned from the combination of drug-eluting balloons and bare metal stents in terms of bailout stent implantation is that it seems that endothelialization of the stent, of the bare metal stent, is delayed or seems to be delayed. We have seen after interruption of dual antiplatelet therapy at 4 weeks, combining drug-eluting balloon with bailout bare metal stenting, that some patients came back a couple of weeks after termination of dual antiplatelet therapy with acute stent occlusion. We cleaned the stent, there was nothing, there was no virtual stenosis present. So based from this early experience, combining drug-eluting balloon with bare metal stent as a bailout indication, we extended our dual antiplatelet regimen now to 3 months following DB plus bare metal stents.
We follow the same rules. I mean, we prolong the the dual antiplatelet therapy because we have always bad experience of any interruption of dual antiplatelet therapy in patient for surgery or any reason.
It's not scientifically proven, but it's clinical experience we made.
But I don't know who is going to finance such study today.
Yeah.
Probably no company. Do you have another comment?
No, I fully agree. It's just case reports. I've seen a couple of months ago in Japan angioscopic images of drug-eluting stents 1 month after implantation. There was no neo-intima or re-endothelialization at all after 1 month. So also for me, although it's not a scientific evidence, but we prolong this combination therapy for at least 3 months.
It's okay.
That was the silver pretext.
What is remaining for surgery? Classical question for the surgeon.
Yeah. Well, in fact, we have 3 remaining indications in our service for surgery. It's first is the endovascular failures. So we have a technical success rate nowadays almost about 95%, but still 5% we are not able to pass, even from retrograde, anterograde, combined, and so on. So this is an indication. Another indication is the real coral reef from head to toe, what is also difficult in surgical terms. And then the last indication is, as we call these patients, the frequent flyers. So the patients that had already in, let me say, 2 years, 4, 5 endovascular procedures, in-stent restenosis, re-restenosis, and so on. Finally, we end up with bypass surgery. So these are the 3 remaining indications.
In our center, the vascular surgeon considers that there is no limit to restenosis. As long as they can open an artery with a balloon or a stent, they propose to continue instead of doing surgery.
Of course, also there we have the cost effectiveness discussion. Yes. So instead of doing 23 endovascular procedures, probably 1 efficient bypass can be, in terms of cost effectiveness, better.
The keyword is efficient.
Yes.
I think we had a beautiful day. I think I am very optimistic of what is going to happen in the treatment of SFA. In my opinion, it's more clear because I would say the situation for me were confused 4 or 5 years ago. We had a lot of devices proposed, a lot of stents proposed, a lot of type of balloon cutting, etc. So we had a lot of devices, and the people were coming in every session. This is the new device to use. This is the new device. And today, for me, I found that our life is more simple. Debulk when it is necessary, or aspirate or thrombectomy. prepare with a balloon and treat the patient, if possible, with a drug-eluting balloon, if it's sufficient, and place a drug-eluting stent when it is necessary in the SFA. But we'll have over time to discuss. Thank you for coming. Thank you for being with us in Nancy.
Thank you.
Koen, Thomas, and Jay. Thank you very much.
Welcome.